Imagine you are maybe 3 months postpartum. You are profoundly sleep deprived.
Oh, just completely depleted in every sense.
Right, entirely physically depleted. And you might be feeling, incredibly disconnected from your own anatomy.
Which is so common, yeah.
So you open your phone, and within seconds, the internet is aggressively serving you these targeted ads claiming that a quick 20-minute laser treatment or a minor surgery will just magically rejuvenate everything.
Like it'll just snap your body right back to its pre-baby baseline.
Exactly. And honestly, when you're in the thick of it, it sounds like an absolute lifeline. But today, I am your host, and we are cutting through a billion-dollar marketing machine surrounding postpartum vaginal tightening to figure out what is actually happening to your body.
Because the gap between those Instagram ads and the actual clinical reality is, well, it's vast.
Yeah.
I'm our resident expert today, and we are pulling from a massive stack of medical sources for this deep dive.
Yeah, we've got official NHS guidelines, data from the National Institute for Health and Care Excellence, or NICE.
Right. Plus, insights from clinical pelvic physiotherapists and actual clinical data from cosmetic gynecology surgeons across London, Turkey, and the U.S.
It's a lot to unpack, but our mission here is to give you, the listener, a clear, evidence-based timeline.
Because a totally different narrative emerges when you actually look at the biology. One that requires an understanding of hormones and a widely misunderstood healing timeline.
We are answering a highly requested topic today, but one that usually only gets whispered about, How long should you wait after childbirth before considering vaginal tightening?
And we're doing this with zero judgment.
None at all. Whether you recently had a baby, are planning to, or you're just, fascinated by the incredible and sometimes frustrating mechanics of the human body, we are going to lay it all out.
We'll explore why patience is a biological mandate and really walk through your actual options.
Right, from physical therapy to high-tech devices all the way to surgery, so we really have to start with that timeline.
We do, because if you look across the board at the clinical consensus, there is a hard rule. You need to wait a minimum of 6 to 12 months after childbirth before doing anything invasive.
6 to 12 months.
Yeah. The immediate postpartum period is just an absolute no-go zone.
Which, I have to say, if you are sitting there at 3 months postpartum feeling incredibly uncomfortable, a year probably sounds like an eternity. Why is that wait so non-negotiable?
Because your body is essentially an active construction zone. In the immediate aftermath of childbirth, the tissue is in a state of acute trauma and repair.
We're talking about healing from perineal tears, right?
Tears, episiotomies, significant swelling, and obviously extreme physical stretching. But that visible physical trauma is actually only half the story.
Yeah, this is the part that completely blew my mind. It isn't just about the physical stretch of the tissue.
No, not at all.
It's about this fascinating biological conflict called genitourinary syndrome of lactation, or BSLO.
GSL is the hidden engine behind so much postpartum discomfort. When you are lactating, your body pumps out massive levels of a hormone called prolactin.
To drive the milk supply.
Exactly.
Yeah.
But prolactin doesn't exist in a vacuum. Its presence actively and aggressively suppresses estrogen.
Which seems counterintuitive. Why would the body deliberately suppress estrogen right when you need it to heal?
Well, it is an evolutionary mechanism. Historically, suppressing estrogen halts ovulation.
Oh, I see.
Yeah, it acts as a natural biological birth control. It spaces out pregnancies so a mother can focus all her metabolic energy on nursing the newborn.
That makes sense from an evolutionary standpoint.
Yeah.
But it kind of backfires for healing, right?
It does. The unfortunate side effect of this trick is that estrogen is the master builder for your vaginal health. It maintains the wall thickness, ensures proper lubrication, and boosts collagen production for wound repair.
So, by suppressing estrogen, lactating mothers are thrown into what clinicians call a hypoestrogenic state.
Right.
Which is chemically almost identical to menopause, isn't it?
Chemically, yes. The tissues become incredibly thin, dry, and friable.
Friable meaning they tear easily.
Exactly. So if a surgeon or a practitioner tries to perform a tightening procedure, whether that's applying laser heat or physically cutting the tissue, while your hormones are entirely out of balance, it's a recipe for disaster.
Because the body simply doesn't have the estrogen-driven building blocks to actually heal the injury they're creating.
Precisely. You are operating on compromised tissue. It drastically increases the risk of unpredictable scarring and can actually worsen the laxity or the pain you are trying to fix.
It's like trying to tailor a highly structured custom suit for someone while they're in the middle of actively losing 50 pounds.
That is a great way to look at it.
The fabric, which in this case is your tissue, is in a temporary extreme state of flux.
And the tailor, in this scenario, your surgeon, is flying entirely blind. If they make permanent cuts while your estrogen is suppressed and the tissue is artificially thinned out, the final result is going to be completely skewed once your hormones do bounce back.
Right. So the question isn't, how many weeks has it been? It's whether that hormonal tug of war between lactation prolactin and tissue building estrogen is actually finished.
Exactly. True recovery requires waiting for that environment to stabilize.
But you'd think that after enduring months of thin, dry tissue caused by GSL, patients would be jumping straight into the surgical chair the absolute second their hormones stabilize.
You would think so.
Yeah.
But the medical data pushes them in a completely different, almost frustratingly simple direction first.
We are talking about active waiting.
Right. Passive waiting doesn't fix the mechanics. This is why guidelines from health bodies like the NHS mandate conservative pelvic floor physiotherapy as the absolute first line of treatment.
Long before a laser or scalpel is ever even considered.
Way before.
But before we get into the actual physical therapy, we really need to separate two distinct issues that often get lumped together. We need to distinguish vaginal laxity from pelvic prolapse.
This is a crucial distinction. Vaginal laxity refers to the looseness of the tissue itself.
The symptoms are things like a lack of friction during intimacy, right?
Right. Or air trapping, which is sometimes called queefing, or even noticing that tampons are slipping out because the canal just isn't gripping them.
Okay.
And prolapse. Prolapse, on the other hand, is a structural failure.
That's when things actually drop.
Yes. Prolapse occurs when the pelvic organs, so the bladder, the rectum, or the uterus, lose their connective support and physically push down into the vaginal canal.
You might feel a heavy bulge or a dragging sensation.
Exactly. They are related mechanical issues, but they require entirely different assessments and treatments.
So for the laxity, the looseness, the standard protocol involves specific, targeted exercises. The clinical guides outline fast and slow Kegels.
Right. The physios are very specific about this. The slow ones involve holding the contraction for 5 to 10 seconds.
Wow, 10 seconds is a long time.
It is. You aim for 10 repetitions, and you combine that with abdominal hollowing.
Which is drawing your belly button towards your spine to engage the deep core.
Correct. And you can start these gentle engagements as soon as any catheter is removed and your pain allows. You don't have to wait the full year for this part.
And the clinical data on this is striking. When researchers looked at first-time mothers a year out from delivery, a staggering 58% reported some form of sexual dysfunction.
That is a massive number.
But the mothers who engaged in dedicated pelvic floor physiotherapy saw a 45% decreased risk of feeling that specific sensation of vaginal looseness.
The active waiting really pays off.
Wait, I have to push back on this, though, because geometrically, it just doesn't make sense to me.
Okay, how so?
If a baby's head just physically stretched the vaginal mucosa like the actual skin and tissue of the canal, how is squeezing a muscle underneath going to magically shrink that stretched skin back down?
It doesn't.
It doesn't.
No, Kegel exercises do absolutely nothing to shrink the vaginal mucosa itself.
So how are 45% of these women feeling tighter?
Think of the vaginal canal like a sleeve.
Okay.
If the fabric of the sleeves gets completely stretched out, you can't magically shrink the fabric just by flexing your arm.
Right.
But if you build up a massive bicep underneath it, that sleeve is going to fit snugly again. The Kegels are building the bicep.
Oh, wow. That is the perfect way to visualize it.
When you do these exercises, you are targeting the levator antemuscles. These muscles surround the vaginal canal, essentially acting like a dynamic muscular corset.
So by thickening and strengthening that surrounding muscle wall, the canal itself dynamically narrows.
Exactly. You are providing a thicker, stronger backing to the vaginal tissue. The skin itself might still have some laxity, but the strengthened corset creates more friction and support.
It basically resolves the sensation of looseness without ever needing to alter the tissue itself.
Oftentimes, yes. It completely resolves it.
Okay, so you build up that bicep, your hormones settle down after you finish nursing. But what happens if that fabric, the tissue itself, is still causing you significant distress?
Like if it's uncomfortably dry.
Yeah, or the laxity is still interfering with your daily life. That brings us to the high-tech options, right?
It does. When conservative muscle therapy has reached its limit, the next tier involves energy-based devices. The clinical data focuses heavily on two main categories,
Radiofrequency devices like Thermiva.
and fractional lasers, such as the Mona Lisa Touch or the Orbium.YAG.
And the way these work is wild. They rely on controlled thermal injury. It's almost like microneedling or a laser facial, but for the vaginal canal.
That's a great comparison. You are intentionally tricking the body into a repair response. Whether utilizing radiofrequency waves or laser light, these devices heat the vaginal tissue to a very specific controlled temperature.
Usually right around 40 to 45 degrees Celsius, according to the sources.
Right, just enough to sound a biological alarm that says, hey, we're injured, without actually causing a burn.
And in response to that heat alarm, your body rushes cells called fibroblasts to the area.
Yes, fibroblasts are basically microscopic construction workers. Their entire job is to lay down fresh, bouncy collagen and elastin.
So by applying this heat without cutting the skin, you trigger the body's natural regenerative processes to thicken the tissue, restore elasticity, and dramatically improve blood flow.
It's quite elegant. Patients often describe the radiofrequency treatments as feeling like a warm stone massage with essentially zero downtime.
Wait, hold on. As a listener, this next part in the source material is incredibly frustrating. We have to talk about the medical controversy here.
We absolutely do.
Now, we are not taking sides here. We are just looking at the source material to try and convey the ideas impartially. But on one hand, you have the UK's NICE guidelines explicitly stating that the routine use of energy devices for cosmetic vaginal laxity is not endorsed.
Right.
And then you have the US FDA waving a massive red flag. They issued a stern warning against using lasers for cosmetic vaginal rejuvenation, citing serious risks of vaginal burns, scarring, and chronic pain.
This is a very strong warning.
But then on the other hand, you have doctors and recent systemic reviews saying these devices are miracles for dryness and atrophy. I mean, who are we supposed to trust here?
It is a classic regulatory standoff. And making sense of it really requires looking at the objective data from adverse event registries.
Like the MIU database.
Exactly. When researchers analyzed the MIU database, which tracks medical device complications, they found that severe adverse events, like those burns the FDA warned about, are actually exceedingly rare.
Really? Even with the warning?
Yes, especially given the sheer volume of these procedures performed globally.
So why the massive warning from the FDA then?
It really comes down to the why. The clinical indication for the treatment. The risk-benefit ratio shifts drastically depending on what you are treating.
Oh, I see.
If a patient is experiencing debilitating pain during intimacy or severe tissue atrophy due to genitourinary syndrome of lactation or menopause, the potential relief from a laser treatment far outweighs the minimal statistical risk of a complication.
Because it's a medical intervention for a real medical problem.
Exactly. But if someone is just looking for a cosmetic aesthetic.
Right. If the procedure is marketed purely as a quick fix to achieve, like, a pre-baby tightness.
Then medical boards are incredibly hesitant to endorse it. The threshold for acceptable risk is always lower when a procedure is elective and purely cosmetic.
That makes total sense. This is why thorough assessment by a qualified gynecologist is critical, rather than just, walking into a med spa for a quick laser session.
Absolutely. You need a medical professional to evaluate the tissue.
So even with the strongest pelvic floor corset, and even with fresh collagen from a laser, some people are dealing with severe structural damage.
Tears that didn't heal right, or deep muscle separation that physical therapy simply cannot bridge.
And that brings us to the most intense option, surgical intervention. Specifically, vaginoplasty.
Vaginoplasty is fundamentally different from the energy devices because we are no longer relying on the body to regenerate collagen. The surgeon is physically altering and reconstructing the anatomy.
It's typically a day case procedure, right? Taking about 1 to 2 hours.
Yes, and they often use TIVA, total intravenous anesthesia.
Which skips the anesthetic gases, so you wake up faster without that horrible post-op nausea. I love that. But what is the surgeon actually doing down there for 2 hours?
They are performing a structural reduction. First, the surgeon carefully trims away the excess stretched vaginal mucosal lining.
Okay, trimming the fabric.
Right. Then they dissect deeper to locate those levator muscles we talked about. They physically pull those stretched muscles closer together and suture them firmly in place using strong dissolvable stitches.
They are manually decreasing the physical diameter of the canal.
Exactly. And because they are deep in the muscle tissue, the recovery is rigorous. Patients are given strict instructions for absolute pelvic rest for 4 to 6 weeks.
Wow, 4 to 6 weeks. That means no sexual intercourse, no heavy lifting, no intense exercise, and no tampons.
That timeline is biologically critical. Those deep muscle sutures are holding the entire reconstruction together under tension.
So they need uninterrupted time to fuse and heal.
Right. Any premature strain, heavy lifting, or insertion can literally rip those sutures, causing internal bleeding or a complete failure of the repair.
Which brings up a massive flashing neon caveat for anyone considering this. We talked about waiting 6 to 12 months postpartum, but for surgery, you should ideally wait until you are completely finished having children.
Yes. A vaginoplasty rebuilds the vaginal walls and tightly anchors the pelvic floor. If you undergo a subsequent vaginal childbirth, a baby's head will forcefully stretch and tear those newly reconstructed tissues all over again.
It will place immense strain on the surgical repair and effectively undo the surgery.
Completely undo it. So unless you are committed to elective C-sections for future births, this intervention must wait until your family is complete.
This raises the ultimate question for me, looking at all these sources. If a vaginoplasty trims the tissue, sutures the muscles, and basically turns back the clock on your physical anatomy, does it actually guarantee a return to pre-baby sexual satisfaction?
The clinical data provides a very grounded reality check here. Surgery fixes structure. By decreasing the diameter of the canal, the surgeon increases the potential for physical friction. It is pure mechanics.
But sex isn't pure mechanics.
Not at all. Sexual satisfaction, desire, arousal, and climax are highly complex psychological, neurological, and interpersonal responses.
Right. If you are deeply exhausted from caring for a toddler, or if the hormonal shifts have impacted your libido,
Or if you are carrying anxiety about your new body. Physically tightening the vaginal canal will not magically fix your sex life. The anatomy is only one component of the entire experience.
that is such a vital point. So to summarize the core timeline for our listener today, give your body grace and time. You have to wait at least 6 to 12 months to let the physical trauma heal and to let that evolutionary mechanism of GSL finish running its course so your estrogen can return.
And do not wait passively.
Right. Utilize that time to build up your pelvic floor bicep with physiotherapy. And only after that foundational healing should you explore the high-tech options, saving surgical vaginoplasty for when your family is fully complete.
It really is a staged, logical approach to recovery that respects how the body actually heals.
But before we wrap up this deep dive, I want to leave you with a final, slightly provocative thought to mull over. We spent this whole time talking about timelines and procedures based on this idea of fixing damage.
Right, repairing the broken parts.
Exactly. But looking at how complex desire and satisfaction actually are based on the sources, what if our modern pursuit of achieving pre-baby tightness is fundamentally flawed?
That is a massive paradigm shift.
What if, instead of viewing postpartum anatomical changes entirely as, broken damage that must be aggressively reversed, we viewed this as an entirely new baseline?
I love that. You grew a human, your body underwent a massive evolutionary process.
Perhaps true sexual satisfaction postpartum isn't about desperately trying to rewind the clock to a past version of yourself. Maybe it's about exploring, understanding, and communicating with this newly evolved anatomy.
If the mechanics have changed, maybe we shouldn't be trying to force the system back into an old mold. We just need to learn how to navigate the new landscape.
Exactly. Thank you so much for joining us on this deep dive. Keep asking those tough questions, keep questioning the marketing, and most importantly, stay relentlessly curious about your own health and your incredible body. We'll see you next time.